remember experiences from your school days, even long after you've graduated from school? I can't help but remember this one episode that I had, and it comes back to me very often. Every time I'm doing ab exercises in the gym, actually, is when I remember it. But I used to have a friend who was diagnosed with epilepsy very early on in life. And a couple of times we did witness her seizures in the classroom. And you know how children are curious, and I was a very curious child. So I often used to ask her, what does it feel like? Like, what goes on in your body and your mind when you're vibrating like that? Because, you know, I've never had to experience something like that, and most of us don't. So it's difficult to really empathize with what someone's going through. And I remember once she took me to her house, and you used to get those belts earlier, which you wrapped around your waist and it would vibrate to make you lose belly fat, which is why I remember this every time I'm in the gym. But she took me home, and we would have been about 14 or 15. And she put the belt around me and she put it on high intensity. And it was unnerving. And it instilled in me an incredible amount of respect for those who live and manage their epilepsy. This is Sonali Acharji, and you are listening to Health Wealth, a podcast that really wants to educate you on every aspect of your well-being, but also leave you with the motivation and the solutions to make the right choices for yourself. World Epilepsy Day is around the corner, and very often I refuse to do episodes based on world days, because I find that the average listener, the average person, would be interested in a topic regardless of whether there is a day or not. So I keep getting messages saying today is World Nail Day, or World Hair Day, or World Breast Cancer Day, or every organ, every disease seems to be having days, and it gets very overwhelming because everything on the internet talks about that one disorder or that one disease, and I feel like, why should I do what everyone else is doing? Why did I make an exception for epilepsy? It's actually a very a story that brought a lot of awareness to me, that I asked somebody, that I asked a fellow journalist, that why do you do stories around World Health Day? You know, there are certain things that deserve to have an awareness day, because the more you talk about it, the more people realize that, you know, this is another condition, this is another, you know, issue that can come up in their bodies, or this is what other people are going through, and the sort of empathy that's needed for, you know, people with various disorders can then come up, and also the awareness to, you know, get to treatment and diagnostics on time. And I realized that epilepsy is definitely one of them, because you know, we are on our 84th episode, and it's never struck me that epilepsy deserves an episode for itself. So I decided that it's time to start taking these World Days seriously and respecting the fact that they are bringing a lot of awareness to certain disorders and conditions. So to help us learn more about epilepsy and to really educate us on the life of an epileptic patient, what are the treatments available, we have with us today Professor Manjari Tripathi. She is the head of Department of Neurology and at AIIMS, New Delhi, but she's also in charge of their comprehensive epilepsy program, which is again a program I didn't know about till we decided to do this episode. So I'm learning already. Hello, ma'am. How are you?
Good morning. You know, I'm doing pretty well and ready to answer your queries.
Can you, maybe before we even get to epilepsy, can you tell us about the work that you're doing with the comprehensive epilepsy program?
So the comprehensive epilepsy program is aimed at a person with epilepsy. And a person with epilepsy has a life and aspirations. And the life and aspirations revolve not just around the disorder, but also around simple things which we take for granted, like education, marriage, vocation, driving, etc. Now, once we see a person with epilepsy, we do write a prescription. But writing the prescription and controlling the seizures is but one tiny aspect of the whole disorder. Because unfortunately, the community and the society attach a lot of stigma to this disorder, because of which, even though the disorder may be this big, the burden is this big and the stigma is even bigger. Hence, we have to address those issues which affect the patient, whether it be their diet, their weight, their education prospects, their marriage prospects, their prospects of having children, and getting to live just like any other individual, and the disorder not labeling the person, but the control enabling the person to be as normal and functional in the society.
And what is epilepsy? We've all heard bits and pieces, but I don't think anyone has a full, thorough understanding of what it is.
Absolutely. So, we have these tiny millions of neurons in our brain, and they are working in perfect synchronization, in perfect harmony. Even if I have to lift my hand like this, there is a bunch of them firing here so that I precisely can lift my hand like this. Now, in epilepsy, there is a sudden, unexpected, uncontrolled, excessive discharge of these neurons, a bunch of them in a particular part of the brain or the whole of the brain. And this abnormal discharge is enough for the patient to have an episode which comes out of the blue. It's unexpected. It takes over the patient. It can be of two major types, a big one or a small one. And the person loses control over himself or herself. And for, few minutes, this continues. And when the person regains consciousness, they have, probably no awareness of what's happened. But what's happened is enough to create bullying in the school or ridiculing in the school because the schoolmates don't know about it, or to create, a storm in the family life of a married woman. So epilepsy is nothing but the loss of control of one's own body due to a sudden abnormal excessive discharge of a bunch of mischievous neurons.
And I love how you say that, I'm actually sort of thinking about my neurons right now because I have to ask the next question. When you say episode, you mean a seizure, right?
Yes, absolutely.
Can you explain a little bit more on what that might visibly look like?
So broadly, seizures are of two kinds. One is an unprovoked seizure and the other is a provoked seizure. So let's talk about the provoked seizure first, which is not epilepsy. So what is a provoked seizure? Suppose I have very high fever. Suppose I have, a low sodium in my body, a low calcium in my body, or I have an acute brain infection like encephalitis, or I have just had a stroke just now, or, I've taken a load of alcohol, or I've taken drugs which can provoke seizures. So like the quinolone antibiotics, tramadol, propranolol, habituating, addicting drugs, they can all trigger seizures. So these are seizures which are triggered within few hours and definitely within few days, within 7 days of an acute insult. That's a provoked seizure, and this is not epilepsy. Whereas unprovoked seizure, and unprovoked seizure is where you don't have any of these, just out of the blue, without any rhyme or reason, or the rhyme or reason may have occurred 10 years in the past in the form of a head injury. Without any acute or recent rhyme or reason, the person has, big attacks. And the big attacks are with shaking of both the hands and the legs, a vocalization, the saliva coming out, the person falling to the ground, injuring himself, the urine coming out. So that's the big attack, which we call the generalized tonic-clonic seizures. They can have smaller seizures, which are unprovoked. And these smaller seizures can be of different types. They may be just with blinking of the eyes, or loss of touch with the surrounding and non-responsiveness. Or they may be just sudden turning of head and the eyes to one side. Or they may just peculiar habit, which may occur for 2 minutes, like lip smacking or picking clothes. And the person is usually not aware. Sometimes the patient is aware. And there can be an aura. A person can come to know that the seizure is coming in the form of a rising sensation from the stomach, or an abnormal smell, or some sound in the ear. So those are smaller seizures or focal seizures. So broadly, these unprovoked seizures can be generalized tonic-clonic, or they can be smaller seizures or focal seizures or smaller generalized seizures, where there's just blank episodes. So these unprovoked seizures, okay, these unprovoked seizures, if they occur 2 or more, or a single unprovoked seizure where the chance of recurrence is more than 60%, is epilepsy. Okay, the provoked seizure is not epilepsy. If somebody has had an alcohol binge and convulsed, it's not epilepsy. If somebody has taken cocaine and convulsed, it's not epilepsy. If somebody has taken ciproflox for typhoid and convulsed, it's not epilepsy. It's just a provoked seizure. Unprovoked seizures, with a single seizure with more than 60% chance of recurrence. Now, the chance of recurrence is determined by the neurologist, by doing the EEG, the MRI, etc. So those are epilepsy. Yeah.
Right. So supposing, I've had an unprovoked seizure and so on. So the first thing you do is you go to a neurologist and let the neurologist decide, or do you go to a psychiatrist, or do you go to, who's the best person to go to for a diagnostic?
So the go-to person who can completely take charge of your seizures is the neurologist, because it's their business, it's their training, it's their learning. And believe me, even today we continue to read. And neurology is one field where there are updates every day. So the neurologist is the go-to person, whether it's an adult neurologist or the pediatric neurologist. And there are several in our country. Yeah.
And are there any other symptoms of epilepsy, or is seizure the only defining one? Is there a way to know that, this child born might turn out to be epileptic?
Okay. So we do not call a person as epileptic. We just say a person with epilepsy or people with epilepsy. That's less stigmatizing than saying she's epileptic, because then you're defining the whole person as epileptic. Okay. So yes, of course, there are 2 major kinds of seizures, which I told you, the convulsive kind and the non-convulsive kind. The non-convulsive kind don't manifest with motor manifestations, so they're not so visible. They can be just perceptions by the patient, and the perception may be in sudden few minutes or seconds of extreme fear, or a rising sensation in the stomach, or it could be a sudden, sensation of the hair standing on one side of the body, which we know as piloerection. Or it could be just a sudden smell, which is a burnt rubber smell, which lasts for a few seconds. So these are non-convulsive seizures. They will not be visible to me or you, and they go missed, because the patient will, or the person will say that something is happening, but nothing is visible to anybody. And so they'll say, oh, he's making it up, or he's, psycho. And those are the kind of patients who may end up going to the psychiatrist. But then the psychiatrists are pretty well aware that this is episodic and stereotypical, and it's definitely the same episode and stereotypy happening again and again. So this is a seizure, and hey, go to the neurologist.
Mm-hmm. I know this because, there's the story of Joan of Arc. And when we were reading it in school, I came across somebody who told me that they suspected she had epileptic episodes because she could hear God. And, there was this sort of hypothesis going on that she can hear God because she has epilepsy. So, at that point, I thought, okay, there are more symptoms to epilepsy than just a seizure. Is that something that can happen? Can you hear voices? Or
they can hear formed as well as unformed. They can have hallucinations. We call it hallucinations. So if the seizure is coming from somewhere near the auditory cortex, which is somewhere here, okay, so then you can get a ringing sensation, you can get a buzzing sensation, you can even hear music, and you can hear specific music. So there was one patient who could hear only Jewish pop, and she was not a Jew. So you could hear strange sudden music, and you could hear sudden voices. So this is known as an auditory formed aura. Whereas if you hear only a buzzing or a humming, that's an unformed auditory aura. So it's coming from near the unformed is coming from the main auditory cortex, and the formed is coming from the auditory association cortex. Similarly, you can also see things. So we had a patient who would see a girl in red before the episode. We had a patient who would see dancing girls before the episode. And we have patients who see starry lights, or we see, wavy patterns before the episode. So wavy patterns and starry lights are unformed, and forms like seeing a fan or seeing a lady is a formed visual hallucination. The form visual hallucination is coming from the from the visual association area, and the unformed is coming from the primary visual area. So it helps us localize, and yes, it could be a seizure.
Yeah, actually, I'm sure it must be extremely traumatic for the person who's going through it. But, me listening to you, it instills in me this, almost awestruckness for our brain. I mean,
Absolutely.
something wrong, and can you imagine like being able to hear another language? And I mean, it's incredible what our brain is capable of doing, when you hear things like this. Is there an age at which symptoms start turning up, seizures, for example?
So anybody with a brain can have seizures. So a newborn kid has a brain, and all of us have a brain till we die. So anybody, any age, can have a seizure. It can happen to anybody, anytime. And it can be due to multitude of reasons. Okay. Now, in a newborn, it could be just because during birth, there was a decrease in oxygen of the brain because of the birth process being prolonged, or there being a cord around the neck, or there may be, aspiration meconium and prolonged labor. So it could be after birth in a neonate, 1 month old or so, where there's some infection like a neonatal meningitis, encephalitis, or sepsis, hypoglycemia. It could occur in an infant till 1 year of age due to, again, meningitis, encephalitis, and of course, certain birth anomalies of the brain, or, due to certain congenital conditions or syndromes like Dravet syndrome, etc., and infantile spasms. It could occur in a 1-year-old to an adolescent due to certain epilepsy syndromes, again, due to damage to the brain which occurred during delivery in the past, or a head injury, or due to a worm in the brain, which we call neurocysticercosis, or developmental anomalies in the brain. It could occur beyond adolescence, and adolescence due to particular genetic syndromes like JME, which is juvenile myoclonic epilepsy, or again, the same, the brain trauma, head injury in the past. And that's why we are particular to wear a helmet and a seat belt, etc. And of course, it could occur due to a neurocysticercosis, just going to the brain, or an infection, or a past TB in the brain, or due to sclerosis of the part of the brain which we call mesial temporal sclerosis, or it could occur in old age due to a stroke. So the patient had a stroke today, but 6 months later has 2 or more seizures and has epilepsy, or a brain tumor, or a genetic condition. So the etiology is so vast, and no one person's epilepsy, no one person's seizure experience is the same as the other. You can bunch them together, but each person's lived experience is different. And that is what makes it a unique disorder. And that is why you need a comprehensive program.
Yeah. As I was researching on this episode, I came across this very interesting fact from the Sumerian times. I think this is 2,500 years before Christ. And they believed that epilepsy was associated with the god of the moon, Sin. And if you broke religious or social rules, or if you, essentially cheated on your partner or did something wrong, that you would get epilepsy. Now it's many, many, many centuries later. Do we have a better understanding of what happens?
Yeah, unfortunately, this disease, has attached to it several myths, and we are still living with those myths. Believe, people believe that the person has been spooked, उस पे भूत प्रेत का असर पड़ गया है, या it is something bad he did in the past life which is coming back, or now those were the days when we didn't have science, and science is the cure for all the myths and the misunderstanding. You have to dig deeper. You have to learn how a disorder happens. And believe me, where we stand today is based on robust scientific evidence, robust studies done at basic level, at human level, and advanced, even now AI level, where it is known now that it is just this bunch of neurons. And you could have done whatever. If these neurons decide, due to any reason, and the reasons I told you, there are several etiologies, to misfire, they will. It's got nothing to do with your past life or bhoot pret or being unfaithful or having a high, sexual activity. So these are all myths. Unfortunately, these myths are more prevalent than facts and science. And that is why it is essential that, communities like you come forward to spread awareness. And whatever amount of awareness is spread for this disease, I believe is less, because the myths are so pervasive in the society, and this leads to discrimination, this leads to stigma, this leads to people getting left behind, this leads to people being less sensitive to the person with epilepsy. And these myths have to be just thrown into the dustbin. So really,
Yeah.
those are all myths.
And it also lead to so much of control. Can you imagine if, mummy said that eat your palak or you'll get epilepsy? Next thing you know, you have no choice but to eat your palak. So, I'm really glad that, there is a day to spread awareness on epilepsy. Coming to treatment, again, we've seen some horrible treatments for epilepsy. They've tried bloodletting, some very strange therapy called cupping therapy, where I believe cups were placed on the person's back. One very good therapy, which was drinking wine, but that depends on your perspective on wine, and starvation and the keto diet and so on. Where are we today? Modern science has advanced. What treatments do we have?
Absolutely. Even in India, we have, different cultural aspects of what you just said. So we have centers in the country where people go to, the alternative practitioners, and they dig out worms from the ear, and the fellow says, you've got cured of your epilepsy. Or they dig out worms from the nose and they say you've got cured of your epilepsy. Or they do this jhad fook. I'm sure you've seen these tantric.
Yeah, that I've seen. Yes.
Om bhu, whatever, om, whatever. So jhad fook therapy, which is still prevalent in the hinterlands where, medical access may not be available so readily. And also we have claims of, all kind of bizarre claims that this is the cure. So again, these are all non-science based. When I say non-science based is, whenever we prescribe a substance, we have to prescribe it based on evidence. And the evidence is generated by doing randomized double-blind studies, which prove that your intervention is superior to the placebo. Now, none of these have stood the scientific rigor of evidence base. So it's all, again, to be thrown in the dustbin. And people should not resort to this at all. People should consult the local primary health center, the local district health center, the government hospitals in their state, and there are some lovely government hospitals and central institutes to They need a correct management plan, or they need action plan for managing their seizures, rather than getting the seizures because of these kind of crazy therapies while they're cooking and getting burnt. So we've seen women getting burnt. We've seen people getting fractures again and again. We've seen people drowning in the well and dying. We've seen sudden, unexpected death in epilepsy because they haven't sought correct treatment because of these misconceptions again about therapy. So again, there is wonderful medication available in India. Believe me, compared to other nations of the similar stature as ours, we have the older drugs, we have the newer drugs, we have everything possible that, and we have them in the essential drug list. The latest drug is there in the essential drug list. So there is no reason that they should resort to the worms coming out from the ear or the jhar phook. It is a matter of awareness again. And the other thing which interrupts them from taking proper treatment is stigma, because they don't want to disclose to people that they have epilepsy. See, now when they go to the clinic or when they go to the health center, there are 20 other people seeing them in the village. Whereas when they call the jhar phook wala to the house, maybe it's just the family who knows about it. So again, the stigma and awareness plays a huge role in treatment-seeking behavior for these patients.
Yeah. What are the treatments exactly? Like, say I come to you, what would you give me for my epilepsy?
So first of all, as a neurologist, I will confirm that it is epilepsy. The onus lies on me. I should not label or not, diagnose anybody as epilepsy without ruling out the epilepsy mimics. So there are conditions which can look like seizures, okay? So I need a proper eyewitness history, aankho dekhi. Then if that is not available and the fits are occurring again and again, I need a mobile video. Everybody has mobile nowadays, So just capture the event on the video and show it to the doctor. That will tell me clinically that this is a seizure. Then I move on from there to the investigations, which is a non-painful test where I fix electrodes over the head, which is known as electroencephalography, which we do for 45 minutes. And then I move on to either a CT scan or an MRI. And then I calculate what is the risk of recurrence for a single seizure versus multiple seizures. And then I say, okay, this person has epilepsy. Then I try to figure out in my mind whether it's focal epilepsy or generalized epilepsy, because the medication for focal epilepsies is different and for generalized epilepsies is different. Now, we have drugs, which is a first-line management. 70% of patients get controlled with 1 or 2 medicines. 70 out of 100 are going to be controlled on 1 or 2 medicines, provided they take it daily without missing a single dose. And also, they take it in the appropriate dose, tolerated dose. So 2 conditions. One is, do not miss your medicines, be adherent. The second is, the dose has to be appropriate to the body weight. Now, once I start these medicines, 70% will get controlled. Okay? We have good medicines. As I told you, we have the most inexpensive ones. We have the middle class, middle expense. We have the most expensive ones. We have ones which we can use in women who want to conceive normally. We have ones we can use in obese people to make them thin. We have ones we can use in patients who have comorbid migraine to make their migraines and epilepsy both go together away. So we have wonderful drugs. And we play around with these. What suits the patient, what doesn't suit the patient. We also advise diet, a low-carb diet, high-protein diet. Now, sometimes, unfortunately, 30% of people with epilepsy, despite taking their dose daily and appropriately in milligrams, 2 or more medications taken daily with the appropriate dose fail. There, we call it drug-resistant epilepsy. Now, drug-resistant epilepsy is a huge burden, okay? It is debilitating to go on having seizures despite taking medicines. It leads to loss of self-esteem of the person, loss of job, loss of education, loss of marriage life, whatever. This drug-resistant epilepsy then comes to a tertiary center like AIIMS, where we evaluate them with advanced investigations like video EEG, where we admit them and we record the seizures and we document which point in the brain it's coming from. We do an epilepsy protocol MRI, which is a 1 millimeter section MRI, which lasts for about 45 minutes.
Got 45 minutes in that tunnel?
In the MRI, yeah, you have to meditate there in the tunnel. Yeah. So I know it's difficult for the person. I mean, for us itself, it would be difficult. But that is what an epilepsy protocol MRI is. That's what we do at AIIMS. Then, if need be, we still are not able to figure out. MRI is coming normal. We're still not able to figure out. We do much advanced nuclear medicine investigations like PET and SPECT. Ictal SPECT. During the seizure, we inject within 30 seconds the SPECT tracer dye, which is a radionuclide substance. We do magnetoencephalography, which is available in our country. We are one of the developing nations to have it. It's a 306-channel helmet which fits on the patient. So we have all these advanced investigations and we pick out the focus. We chase the focus. Okay. And then we call in the surgeon, who's a neurosurgeon, who's trained in doing epilepsy surgery, removes that focus. So that's resective surgery, which is a cure for these people. Or we do disconnective surgery, where we disconnect that mischievous part of the brain from the rest of the brain. Or we do neuromodulation, where we fit batteries and we send wires either to the vagal nerve or inside the brain. And we fix that and we modulate the currents in the brain. So all this is again available in India. And if the patient is not amenable for surgery, is not a surgical candidate, we have wonderful diets which are run by our dietitians, like the ketogenic diet, which is a very rigid diet, or a modified Atkins diet, or a low glycemic index diet. So basically, you're starving the brain of carbohydrates. You're amping up your proteins and fat and controlling the seizures. So all this is available. All this is available. And again, that's why we are a comprehensive epilepsy center. And these are the various modalities by which we manage our people.
Right. Tell me one question on what you said. You mentioned drug-resistant epilepsy. Because from what we've heard, drug resistance in TB, as a layperson, that's what we normally associate with it. How does epilepsy become resistant to modern drugs?
So there are underlying mechanisms. Basically, it can be a structural lesion in the brain, like mesial temporal sclerosis in this part of the brain. The hippocampus, which is a memory structure, undergoes shrinkage. Or it could be a gliotic scar or a head injury scar anywhere in the brain. The gliotic scar could have occurred due to head injury, due to a prior stroke, a prior injury, a prior neurocysticercosis, prior birth hypoxia, which has damaged both the parts of the back of the brain. Or it could be a prior, infection like TB, any of these. Or sometimes it could be genetic. There are genetic causes of drug resistance.
Right.
So, there are all these causes which the neurologist needs to investigate.
Yeah. I'd like to get to the point of myths and stigma in epilepsy. And one of the mediums through which a lot of myths happen is social media or the internet. So I took a quick scan and had a couple of questions which I think you can answer if it's true or not. When somebody's having a seizure, you need to put food and water in their mouth, and that will calm them down.
So, I'm so glad you asked this, because when somebody's having a seizure, they're essentially in a Valsalva maneuver where they are unable to breathe. The only thing which the caregivers have to do or the bystanders have to do is gently turn the patient to one side, either side, right or left, and let the saliva drool out. Okay, so just turn the person to the side. That's it, fully. Okay. Do not put anything in the mouth. No spoon, no onion, no water,
sugar,
no medicines in the mouth. because the person has no control over these muscles. He is going to aspirate. It will go to the lungs and there will be an aspiration pneumonia. And God forbid it goes to the lungs and there's sudden death. So nothing has to be put into the mouth, not even the fingers. We even find people putting fingers thinking that the patient is going to bite the tongue. Okay. So if the patient bites the tongue will heal. But if the patient bites off your finger, which has happened, the finger goes inside the lungs. This has also happened. Okay. So nothing has to be put into the mouth. And nobody should make them smell a shoe. You know, some people just make them smell a shoe thinking smelling a shoe will make the seizure go away. Now, let me tell you the fact. That's the myth.
Why a shoe?
You see it.
Yeah,
You
would make many things other than a shoe.
Yeah, so that's what happens culturally in our context. तो उनको चाबी पकड़ा देते हैं, लोहा पकड़ा देते हैं, या शू सुंघाते हैं, या प्याज सुंघाते हैं कि दौरा भाग जाएगा. The fact is that all big seizures, 98% of big seizures will stop on their own in 2 minutes. So by the time the family is searching the shoe and coming and making them smell, the 2 minutes are over. So the myth has spread, the shoe has stopped the seizure. But it is the inherent brain mechanisms of stopping seizures. Just as the brain is starting the seizures, the brain endogenously has chemicals which stop the seizures, which kick in 2 minutes. Okay? So the only thing they have to do is turn the patient to the side. And most people with epilepsy will have a prescription of intranasal medication, which the caregiver has to puff into the nostril. That's the only thing. They have to puff that medication into the nostril. These are the only two things. Apart from that, they should time the seizure. If the big convulsion, which is movement, is continuing for more than 5 minutes, I told you, in 98%, this big convulsion stops within 2 minutes. But if the big convulsion is continuing for more than 5 minutes, then we call it status epilepticus. That is a medical emergency. So another bystander has to time the event. How long the motor movements are happening. If the motor movements stop in 2 minutes, nothing to panic. But if the motor movements are lasting for 5 minutes, it's status, intranasal medication, rush to hospital. Okay. Also, the other bystander could make a video of the event so that the clinician knows what's happening during the event. Hence, that's the only first aid and the only things to be done, not, putting water or anything into the mouth.
Or food. One more thing, which was very rampant online, is that epilepsy is contagious. Can you tell me if that's true? If I'm around a person with epilepsy, will I get it?
So it's absolutely so sad that things which are contagious are neglected. So, you find people spitting all over. And you ask them, why are you spitting? Do you know what diseases can be spread through spit? It can be tuberculosis, which we are not able to get control of. It could be COVID in the COVID times. They won't know that, but they certainly know that epilepsy is contagious. That again is a myth. Epilepsy is absolutely not contagious. It does not spread through contact. It does not spread through seeing a person with epilepsy. It does not spread through eating on the same plate or cohabiting together. So that again should be thrown into
something you're born with. So I think we've covered the medical part of it. I'd like to get to some of the happier parts of, what science and medicine can do for people with epilepsy. Now, there are people who have had epilepsy and have been very successful. I believe Van Gogh had it and Charles Dickens had it. In your career, are there some stories of hope or, through successful management, what it can do?
Absolutely. I will not be able to take names, but there are very successful people. In fact, highly intelligent people, doctors, cricket players, students, getting very good education, engineers. There are athletes, there are, the workhorses of the country, common man and women, housewives, all who are leading successful lives and happy lives. And that is only because of one thing, that is having a self-management strategy, being Atmanirbhar yourself in your own management. So a person with epilepsy has to take control of their own management of the seizures. They should not allow the seizures to take control, or the myth and the stigma, or the society to take control of their lives. They have to have the attitude, I have epilepsy, so what? I can read, I can work, I can do anything another person can do, except the dangerous activities like bungee jumping, or climbing a mountain, or paragliding. All the non-dangerous activities can be done by me. That attitude has to be there. Then the second factor is the support given by the caregiver. I have had families where the husband is so supportive, that has transformed the trajectory of the woman with epilepsy. She's had children, they're happy, they are co-partners. I've had men whose spouses have supported them. I've had families where, they have all pitched into the care of a difficult patient. So it is possible, it is not impossible. On the other hand, those who sink into misconceptions and stigma, they have a miserable life. They have, they impose, the family, the community imposes on them a life of exclusion, non-participation, whether it's be non-participation at an individual or community or society or country level. And we've had women getting separated because of this in their marriage. We've had divorces of late, since the girls have also got bold. If the groom has a seizure on the marriage night, the marriage hasn't happened. It's been in the news, you know it. So, we've seen all of this. But this is, sad, because anybody can have any disease, even after marriage. Tomorrow, the husband could have cancer. Does that mean the wife leaves him and goes away? Or tomorrow, the husband could have epilepsy. So does it mean that the wife will leave him and go away?
Yeah.
Or, so when you are down, when anybody is down, it is only human that we help the person get up and, walk again and be as normal as possible. So we've seen all of this, this side and that side. And I can definitely say as a clinician that the positive aspect is the better aspect. And again, reducing stigma and myth. Coming to stigma, there are two kinds of stigma, okay? There is perceived stigma and there's enacted stigma. So perceived stigma, suppose I have epilepsy, I perceive myself, because of epilepsy, to be different than the other. So it's a perception I have. It may not be true. But because of the reactions I've seen, because of, what misconceptions the community has put onto my head, I have this perceived stigma. Now, perceived stigma, we have shown for the first time in the world that self-management helps. Education about epilepsy helps. Yoga helps. We have shown it for the first time, published in the best journals in the world. Okay. The enacted stigma is different. Enacted stigma is what other people enact upon the person with epilepsy. So for a schoolboy who's wet his clothes due to a seizure, it could be bullying or making fun of by his friends. For a married woman, it could be harassment by the mother-in-law and the relatives, the nana, the whatever. So that's an enacted stigma. Now, enacted stigma is very difficult to remove by the person who's suffering. The community has to do something. Your awareness programs have to do something about it. When we have had major diseases get away from stigma, epilepsy is still not out of the shadows. We still see women who are taking anti-seizure medicines in their in-laws' home in vitamin bottles because they cannot disclose. If they disclose, they are removed from the family. So the anti-seizure medicine is in the vitamin bottle, not in, so this is all because of stigma. This is all because of discrimination. The basic human rights are violated in people with epilepsy. And that is where we have to stand up for them.
Yeah. My last question is not so much on epilepsy, but a little bit about you. Just hearing you talk, it must require so much of courage to, witness some of the episodes, especially if they're, slightly more volatile. Um, and also so much of patience to counter myths and misinformation and make sure everyone's taking their medicine daily. I mean, I can imagine how frustrating it must be for a patient to skip the medicine and then, fall sick, and, how that affects a doctor. Where do you get your courage and your patience from?
I think it is from those when you see that there have been transformed lives. And those transformed lives have further changed lives of those around them. So when we see a person with epilepsy who's refractory come around and get integrated and be participative in the family and community activities, that is what gives us courage. So essentially, the courage comes from the people, their challenges, their struggle, and seeing how transformation can happen in lives with simple measures. Just being adherent to medicines with the correct doses or with more complex measures like surgery is what gives me courage.
Thank you. Thank you so much for that. I feel it always brings a new dimension to a listener's life, to hear how doctors find their courage and keep going through, because you have one of the toughest professions. So thank you for sharing that.
Thank you so much for doing this.
I haven't ever witnessed transformation in a person with epilepsy, but I have witnessed it in a dog with epilepsy. There was a dog at a shelter, and she would repeatedly have these seizures, and nobody ever wanted to adopt her because it was just assumed she has rabies or she has distemper, or we'll bring her home and she'll bite the children. And a friend of mine ended up adopting the girl dog, and she was put on medicine by the vet. She lives in a home with 3 children now. She's a bit of a social media phenomenon. She has 4,000 followers, more than me on Instagram. And she is absolutely fine. And it's just that little bit of empathy and support to someone who is unable to do that. And if you give that little bit, you get so much in return. Do you have any stories of empathy healing that you could share? And since we're doing this monthly podcast with AIIMS Delhi, their doctors, is there a particular topic or an organ or a disorder you'd like to know more about? Please write to us. We are available at pods@indiatoday.com. You can also message us on 858889669996. And if you've enjoyed this episode and if it's brought awareness to your life, please leave us a rating. We are there on Apple, YouTube, Spotify, and the India Today website. Okay. Thank you so much, ma'am. Thank you.
Have a good day.
So nice.